high-quality medical and surgical care rendered during the past 2 decades to infants and children with congenital heart disease has resulted in survival of these patients into the adulthood. Accordingly, an increasingly large number of adolescent and adult patients with various forms of congenital heart disease are being seen by the adult cardiovascular specialists. Since echocardiography plays a vital role in the complete assessment of these patients, therefore it is crucial that the adult cardiologist be thoroughly familiar with the echocardiographic features of various congenital lesions. In this tape, we will present and discuss the role of two-dimensional echo, pulsed and continuous wave Doppler, as well as color flow imaging in the diagnosis and hemodynamic assessment of various forms of congenital heart lesions. The types of lesions seen by the adult cardiologist usually represent one of the 3 categories. Firstly, patients who have undiagnosed defects. We still see a relatively large number of adult patients with undiagnosed acyanotic lesions. The most frequent lesions include various malformations of the aortic valve, such as bicuspid, unicuspid, and quadricuspid valves, atrial septal defect, pulmonary stenosis, subaortic membrane, and rarely Epstein's anomaly. The 2D echo diagnosis of congenitally malformed aortic valve has been discussed in tape number 4. The other lesions listed here will be discussed in detail later in this tape. The next category represents patients who have had palliative procedures performed at a young age consisting of aoropulmonary shunt, such as Blalock Taussig anastomosis, or had pulmonary artery banding. These patients come to medical attention in their adult life either because of failure of the shunt or other related complications of cyanotic heart disease. The third category represents an increasingly large number of referrals to the adult cardiologists of patients who have undergone complete repair at a younger age. In this regards, it is worthwhile to note some of the milestones in repair of congenital heart defects. In 1938, 50 years ago, patent ductus was successfully ligated, while in the early 50s, atrial septal defect and ventricular septal defect repair was accomplished. In the mid-50s, tetralogy of Fallot and double outlet right ventricle were successfully repaired, and in 1971, Fontaine operation was performed. It is important for all of us to remember that other than closure of patent ductus arteriosus and suture closure of an uncomplicated atrial septal defect, all other operations designed to accomplish complete repair certainly have significant residua as well as significant sequelae. We will first discuss the 2D and Doppler features of acyanotic lesions, followed by discussion of a systematic and segmental approach for evaluation of patients with cyanotic as well as complex lesions, and finish with evaluation of post-operative congenital cardiac. The acyanotic lesions can be further subdivided into 2 categories: the shunt lesions and the stenotic lesions. Shunt lesions are atrial septal defect, partial anomalous permevenous connection, ventricular septal defect, and patent ductus arteriosus. Let us begin with atrial septal defect, which is one of the most common forms of congenital heart lesion seen in the adult cardiology practice. The 3 most common forms of atrial septal defects are ostium secundum, ostium primum, and sinus venosus types. Before discussing each individual type of ASD, we would like to emphasize that for a complete examination, the atrial septum must be scanned from many different ultrasound windows as are listed here. The subcostal window is particularly important since from this approach the ultrasound beam can be directed nearly perpendicular to the atrial septum, and hence the defect can be confidently visualized. False positive dropout in the region of the fossa ovalis is a frequent problem when the atrial septum is imaged from the apical or paraapical positions, as well as in the parasternal short axis view. In patients with enlargement of right-sided chambers, the right parasternal window can also provide excellent visualization of the atrial septum. Recently, transesophageal echocardiography has provided a new window to the heart, and in particular to visualization of the atrial septum. Proximity of the esophagus to the atria provides high-resolution images of various atrial septal defects and even permit visualization of patent foramen ovale. This, as well as subsequent anatomic slides that will be shown, are provided with courtesy of our cardiovascular pathologist, Dr. William Edwards. This is the typical appearance of secundum atrial septal defect. We are looking into an opened right atrium and right ventricle. For orientation, this is tricuspid valve, and here is coronary sinus, inferior vena cava, and the entrance of superior vena cava. This is the limbus fossa ovalis. A large ostium secundum type of ASD is present in the fossa ovalis membrane. Let us now look at 2D and Doppler examples of ostium secundum ASD. This is parasternal long axis view demonstrating typical features of right ventricular volume overload. The right ventricular cavity is dilated, ventricular septal motion is abnormal, and left ventricular size and function is normal. Note normal coaptation of mitral leaflets with no prolapse. This is parasternal short axis view. Note again that the right ventricular cavity is moderately enlarged, while the left ventricular cavity is of normal dimension. In real time, features of right ventricular volume overload are again evident. This is parasternal short axis view at the base of the heart. This is aortic root, aortic valve. Note that the right ventricular outflow tract is dilated, as well as the pulmonary annulus. In real time, note the normal motion of the pulmonic valve and dilated main pulmonary artery as well. This demonstrates the color flow examination. In real time, note the laminar flow in the right ventricular outflow tract and slight degree of pulmonic regurgitation. This is a low parasternal four-chamber view with apex down orientation. This is right atrium, right ventricle, and the left-sided chambers are here. Mitral and tricuspid leaflets are in normal closed position. Note a large dropout of the atrial septum as seen in this particular view. In real time, note the normal motion of mitral and tricuspid leaflets, the dropout of the atrial septum, and dilated right heart chambers. This is the still frame of a color flow examination in the four-chamber view format. Note here this large bolus of flow directed towards the transducer encoded in colors of red, which represents the shunt across the atrial septal defect coming from the left atrium to the right atrium. Watch this in real time now. This is subcostal examination. This is left atrium, atrial septum, right atrium. Note there is a large defect in the mid portion of this atrial septum. The lowermost portion of the atrial septum is intact, as is the uppermost portion of the atrial septum. This is the entrance of right inferior pulmonary vein normally into the left atrium. This is a freeze frame of color flow examination. Here we see a large bolus of flow directed from left atrium through this atrial septal defect entering into right atrium in this position. Observe this in real time now. We have now placed a pulse Doppler sample volume in the region of the shunted flow across the atrial septal defect. This will demonstrate in real time the characteristic audio as well as the spectral pattern of shunted flow across the ASD. This freeze frame demonstrates the characteristic spectral profile of the shunted flow. Note that the left to right shunt commences during end systole, is holodiastolic, and there is further accentuation after atrial systole. Note also that this is a turbulent flow pattern. This is low parasternal four-chamber view. This is right atrium, atrial septum, left atrium, left ventricle, and this is a markedly dilated right ventricle. Note also that the right atrium is moderately enlarged, and a defect in the mid portion of the atrial septum can be visualized on this frozen frame. The left-sided chambers, in particular the left ventricle, appears of normal dimension. In real time, the features of right ventricular volume overload can be appreciated, as well as the defect in the mid portion of the atrial septum. This is the still frame of color flow examination. Note large bolus of flow encoded in red entering into the right atrium through this atrial septal defect extending from the left atrium into the right atrium. This is the subcostal examination of the atrial septum. This is left atrium, atrial septum, and right atrium. Note that the defect in the mid portion of the atrial septum is clearly visualized in this format. The lower portion of the atrial septum as well as the uppermost portion of the atrial septum are intact. The right inferior pulmonary vein is entering normally into left atrium in this position. This is the still frame of a color flow examination, demonstrating again a large bolus of red encoded flow into the right atrium across the atrial septal defect. Guided by the flow image, we have now placed a pulsed wave Doppler sample volume in the right atrium in the area of the maximum shunted flow. The arrow is pointing to the position of the sample volume. This will again demonstrate the characteristic spectral as well as the audio signals of the left-to-right shunt across the ASD. The characteristic spectral profile is shown in this still frame. The left-to-right shunt commences in late systole and is holodiastolic in timing, and there is further accentuation of the shunt across the atrial septum following the atrial contraction. Note again that the turbulent nature of this flow across the atrial septal defect. In real time, also appreciate the characteristic audio signal of this left-to-right shunt. Now we are demonstrating the continuous wave Doppler examination of the tricuspid regurgitation in this patient. Note high velocity tricuspid regurgitant jet measuring 3.8 meters per second. Now watch this in real time. This high velocity jet indicates presence of modest pulmonary hypertension, which will be further discussed later on. Now we will demonstrate the utility of transesophageal echocardiography in visualization of ASDs in 2 patients in whom standard 2D echo examination failed to visualize the defect. This is the still frame of a 20-year-old patient undergoing transesophageal echocardiography. This is the left atrium, atrial septum, right atrium. The ventricles are off this particular image. Note the clear visualization of the entire atrial septum, and this very small 3 to 4 millimeter size secundum atrial septal defect can be clearly visualized in this still frame. In the color flow mode, this small jet of left to right shunt can be clearly visualized. Note that we are utilizing the conventional flow map with flow away from the transducer encoded in shades of blue. Hence, this left to right shunt will be visualized in shades of blue coming through this small atrial septal defect. In real time, you can clearly appreciate the small jet of left to right shunt across the small defect. This next example is the transesophageal echocardiographic examination of a 34-year-old female. This is left atrium, mitral valve here. This is the tricuspid valve, dilated right ventricle, and note the dilated right atrium. The defect in the mid portion of the atrial septum can be clearly visualized. Note that the lower portion of the atrial septum as well as the uppermost portion of the atrial septum is intact. In real time, you can see the defect clearly as well as the margins of the fossa ovalis membrane. In color flow mode, you can clearly visualize this large bolus of flow going across the atrial septal defect. You can see this vividly also in real time, and the shunt is represented in shades of blue. Now we will discuss ostium primum atrial septal defect. In this pathology slide, we are looking into the open right atrium and right ventricle. Note the right ventricle is dilated and hypertrophied. The typical location of ostium primum atrial septal defect in the lower portion of the atrial septum can be clearly seen. Here is the limbus fossa ovalis with intact fossa ovalis membrane. This is the location of coronary sinus. Also note that the inferior margin of this ostium primum atrial septal defect is formed by the plane of the atrioventricular valves. This is the same heart specimen. We are looking into the opened left atrium and left ventricle. The atrial septal defect in the lower portion of the atrial septum is again clearly seen. Pay attention to the mitral valve. Note the anterior leaflet of mitral valve has a large cleft extending all the way to the base. The cleft in the anterior mitral leaflet is almost always present in patients with ostium primum atrial septal defect and is part and parcel of partial atrioventricular canal defect. This is the 2D echo examination of an 81-year-old patient who is the oldest patient with partial atrioventricular canal defect that we have seen. In this long axis view, note that the right ventricular cavity is markedly dilated, left ventricular dimensions are normal, the mitral apparatus is somewhat unusually oriented into the left ventricle, and this will be better appreciated in real time. The left ventricular outflow tract is normal and left atrium is moderately enlarged. In real time, you can see the features of right ventricular volume overload. Note the abnormal orientation of mitral apparatus and the dilated left atrium. We are now looking at the peristernal short axis view of the mitral valve. Here we are demonstrating the cleft in the anterior mitral leaflet. The cleft divides this leaflet into two nearly equal halves, the medial component and the lateral component. This can be well appreciated in real time. Let us look again at a short axis scan. Note that the interpapillary muscle distance is reduced, and as the scan is extended cephalad, the typical cleft in the anterior mitral leaflet can be visualized. At the base of the heart, sclerotic changes of the aortic valve are evident, and the atrial septal defect cannot be clearly visualized. We are now looking at the four-chamber view. In this image presentation, the apex is oriented on the top, the right-sided chambers are on the right, and the left-sided chambers are seen here. Note that the right ventricle and the right atrium are markedly dilated. The defect in the lower portion of the atrial septum can be very clearly visualized. Another characteristic feature is shown here. Note that both atrioventricular valves insert at the same plane at the crest of the ventricular septum. Further note that there is no ventricular septal defect evident. In real time, note marked dilatation of right ventricle, normal size and function of left ventricle, insertion of both AV valves at the crest of the ventricular septum at the same level, large ostium primum atrial septal defect, and incidentally noted is a large eustachian valve in this position as well. This next example is the transesophageal echocardiographic examination of a 39-year-old patient. This patient had a poor quality transthoracic study because of marked obesity. In this view, the left atrium and left ventricle are here, right ventricle and right atrium in this position. Note this large ostium primum atrial septal defect is clearly visualized. Both mitral and tricuspid leaflets insert at the same level at the crest of the ventricular septum. In real time, you can appreciate the high-resolution image of the atrial septum and of the primum atrial septal defect. In this color flow mode, note that a large shunt can be seen passing from left atrium through this lower portion of the atrial septal defect into the right atrium. Note that we have changed the color map. Now the flow directed away from the transducer is encoded in shades of red. Hence, in this particular example, the shunted flow is seen in shades of red. In real time, you will appreciate the shunt more vividly. The least common variety of atrial septal defect is the sinus venosus type. In this path specimen, we are looking into an open right atrium and right ventricle. For orientation, this is the tricuspid valve, and here is the orifice of coronary sinus. This is the limbus of fossa ovalis with intact fossa ovalis membrane. Note the location of this sinus venosus atrial septal defect being superior and somewhat posterior to the limbus fossa ovalis. Here are the anomalously connected pulmonary veins from the right lung. Remember that anomalous pulmonary venous connection is almost always present in patients with sinus venosus atrial septal defect. 2D imaging of sinus venosus ASD is frequently very challenging and requires scanning in the frontal plane from the subcostal position. This still frame is that of a 36-year-old patient with sinus venosus ASD. We are looking at the crest of the atrial septum. Note clear visualization of this large sinus venosus ASD. The thin membrane of fossa ovalis is intact, and so is the lower portion of the atrial septum. Note in this position is the anomalous connection of right pulmonary vein joining the right atrium at the atriocaval junction. The defect is also clearly visualized in real time. This is the still frame of color flow examination. You can clearly see a large bolus of red encoded flow coming through the atrial septal defect and entering into the right atrium. You'll see this also quite vividly with real-time examination. This is the transesophageal echocardiographic examination of another patient, age 57-year-old. We are looking at the left atrium, atrial septum, and right atrium. Note this patient has sinus venosus ASD, which is clearly visualized on this examination, while this defect could not be visualized from the standard precordial and subcostal examinations. You can visualize this defect in real time now. Color flow mapping shows a large bolus of shunt from left atrium to right atrium. The echocardiographic diagnosis of partial anomalous pulmonary venous connection remains challenging. However, the diagnostic accuracy of echocardiography has been markedly improved by addition of color flow imaging. This still frame is from a patient who has partial anomalous connection with intact atrial septum. This is a right parasternal view with right atrium, atrial septum, and left atrium visualized in these plane. In real time, you'll note that the atrial septum is intact. Color flow mapping confirmed that the atrial septum was intact, and in real time, as we scanned the free wall of right atrium, the anomalous connection of the right pulmonary vein directly to right atrium could be clearly visualized. This is the magnified view demonstrating again very nicely the anomalous connection of pulmonary vein directly to right atrium. Having established diagnosis, next it is important to determine the hemodynamic severity of the shunt lesion. In general, the magnitude of shunt can be readily established by visualizing the width of the color flow jet. In this tape, you have already seen examples of small as well as large shunts. In our practice, we infrequently calculate the pulmonic and systemic flow ratios. The technique and the formula utilized for this calculation has been illustrated on previous tapes. We routinely, however, will calculate right ventricular and pulmonary artery systolic pressure utilizing continuous wave Doppler. In the example that was shown earlier, the elderly patient with atrial septal defect had tricuspid regurgitant jet velocity of 3.8 meters per second. Using the simplified Bernoulli equation, this calculates to a 58 millimeter mercury pressure drop from right ventricle to right atrium. The right atrial pressure in this patient was estimated as 12 millimeters mercury. Therefore, the calculated right ventricular and hence pulmonary artery systolic pressure equals 70 millimeter mercury. During the time of this hemodynamic assessment, patient's blood pressure was 120 over 70 millimeters mercury. Ventricular septal defect is relatively infrequently seen in the adult practice. When seen, it is either a small defect or a large defect with resultant pulmonary hypertension. A simple and practical classification of ventricular septal defects is shown here. Perimembranous ventricular septal defect is the most commonly encountered. Other locations which are less frequent involve the inlet septum, outlet septum, and muscular septum. Here you can see a schematic representation of these defects. This is the location of perimembranous VSD. Outlet VSD is located in this position, while the inlet septal defect is shown here. The muscular or trabecular septal defect occupies position in the muscular ventricular septum and can be variably located, schematically shown in this position. Now we will illustrate several examples of VSDs ranging from small to large size. This is the parasternal long axis view of an 18-year-old patient who has a small paramembranous ventricular septal defect. Note, right ventricular dimension is normal. Here's the ventricular septum, and left ventricular size is also normal. This is the systolic frame of a color flow map demonstrating that during systole, a mosaic color jet enters into right ventricular outflow tract through this small ventricular septal defect. This is a diastolic frame. Mitral valve is in open position while the aortic valve is in closed position. Note that there is continued left to right shunt occurring across the VSD even in diastole. This diastolic left to right shunt is of low velocity, hence is shown in uniform red color. In real time, you can appreciate the sequence of shunting across the small VSD in systole as well as in diastole. We are now performing flow-guided continuous wave Doppler examination. This shows us a high-velocity jet, 4.9 meters per second, and also continuous diastolic forward flow. This is the parasternal long axis view of another patient who is 16 years old and has a small perimembranous ventricular septal defect. The defect could not be clearly visualized on the 2D examination. In the color flow mode, the flow across the small VSD can be clearly seen, resulting in a splash of mosaic colors in right ventricle. Observe this in real time now. This is another still frame of the color flow image demonstrating the shunt across the small VSD. However, when we remove the tissue information, the shunt can be even more vividly appreciated. Frequently, small and medium-sized VSDs close spontaneously by formation of aneurysm of the membranous septum. This is the parasternal long axis view of a 37-year-old patient with the perimembranous ventricular septal defect. Left ventricular cavity is dilated while systolic function is normal. The large perimembranous VSD can be seen right here, which is partially covered over by an aneurysm formation of the membranous septum. You can now see that the aneurysm is partially covering the ventricular septal defect, and there is opening evident right at this position through which residual shunting was still present. Now, as the scan is being rotated into the short axis plane, here's the aortic root with the aortic valve, and a large aneurysm of the membranous septum can be clearly visualized with small residual defect present. More commonly, aneurysm of membranous septum is discovered as an incidental finding, as was the case in this 77-year-old female. We are looking at the magnified short axis view of aorta. Here is moderate size aneurysm of the membranous septum present. This is the right, left, and non-coronary sinus. You can see this clearly in real time. This is the long axis view of the same patient. You can again very clearly visualize the aneurysm of the membranous septum. Here's the aortic valve, and now we'll watch this in real time. We will now demonstrate the features of ventricular septal defect with severe pulmonary hypertension. This is a parasternal long axis view of a 37-year-old patient. Features to note include markedly hypertrophied right ventricular free wall, dilated right ventricular chamber, marked hypertrophy of the anterior papillary muscle. Note here the presence of a large perimembranous ventricular septal defect. Left ventricular outflow tract is widely patent, and left ventricular cavity dimension is normal. Watch these features in real time now. In real time, you can also appreciate that the portion of this redundant tricuspid apparatus is prolapsing through the ventricular septal defect. This is the parasternal short axis view. Note that the ventricular septum is flattened and the left ventricular cavity has a D-shaped appearance. In real time, note again marked right ventricular free wall hypertrophy, hypertrophy trabeculum septal marginalis, and as the scan is taken to the base of the heart, large perimembranous ventricular septal defect with prolapsing of tricuspid apparatus is seen. In color flow mode, bidirectional shunting across the VSD can be visualized. The timing can be best appreciated in color M mode. Here is a freeze frame recording at faster speed for better delineation of shunt dynamics. Note, during early systole, the flow is directed from left to right and is represented in shades of yellow and red. During mid-systole, the pressures in two ventricles equalize and there is no longer any forward flow across the ventricular septal defect. During early diastole, the shunt is reversed, and now the direction of the flow is across the VSD into left ventricular outflow tract during diastole, represented in the shades of blue as shown here. Patent ductus arteriosus in the adults is very infrequently encountered and is also extremely difficult to visualize by two-dimensional echocardiography. Color flow imaging is the method of choice for directly visualizing the shunt. This is a parasternal short axis view. Here is the aortic root, and here is the mildly dilated main pulmonary artery. In this view, we cannot directly visualize the ductus arteriosus. And now, in color flow mode, you can clearly see the shunt. The shunt enters into the main pulmonary artery, and the narrow width at origin is consistent with the small ductus. We have now completed discussion of shunt lesions. Let us turn our attention to stenotic lesions. Since aortic stenosis has already been discussed on tape number 4, in this tape we will discuss subaortic stenosis, pulmonary stenosis, and coarctation of aorta. Discrete subaortic stenosis can either be membranous or fibromuscular. This is the magnified long axis view of a 49-year-old patient with discrete subaortic membrane. Here is the aortic valve, and in this frozen frame you can clearly visualize the membrane in the subaortic position, resulting in left ventricular outflow tract obstruction. Visualize this in real time now. The aortic cusps are normal, with slight fluttering of the right cusp evident. Membrane is also clearly visualized. M mode of the aortic valve is illustrated here. Note a very typical abnormality involving the right coronary cusp. There is early systolic closure, very typically seen in this condition. We will show this in real time now. Most patients with discrete subaortic stenosis develop aortic regurgitation because of the impingement of the eccentric jet on the aortic cusps. This patient also has mild aortic regurgitation. You can see the jet of aortic regurgitation very clearly in this example. In real time, you can also see the systolic mosaic-colored jet in the left ventricular outflow tract in addition to the aortic regurgitation. This is apical long axis view of another patient. In this 28-year-old patient, this membrane could not be well seen in the parasternal long axis view. Note there is concentric left ventricular hypertrophy present and the discrete membrane is clearly visualized. Color flow examination shows a mosaic color jet in the left ventricular outflow tract extending up to the aortic valve. In real time, you can clearly see this eccentric jet and also note absence of aortic regurgitation in this patient. On continuous wave Doppler interrogation, the peak velocity across the stenosis measured 3.5 meters per second, indicative of moderate degree of obstruction. Note again, absence of aortic regurgitation. We will now discuss 2D and Doppler features of pulmonary stenosis. This is a parasternal short axis view of a 93-year-old patient with severe pulmonary stenosis. This patient presented in severe congestive heart failure with low output syndrome. In this view, note that the right ventricular walls are hypertrophied, right ventricular outflow tract is also dilated, and the pulmonic valve cusps are thickened and somewhat calcified. In this systolic frame, doming of the valve is also evident. For orientation, this is the aortic root with sclerotic aortic cusp seen. In real time, pay attention to the doming motion of the pulmonic valve. This is the subcostal four-chamber view. This is left atrium, left ventricle, right ventricle, and right atrium. Features to note include an intact atrial septum, marked right ventricular free wall hypertrophy, and normal systolic function. There's also a small amount of pericardial effusion present. These features are clearly evident in real time. On continuous wave Doppler examination, the velocity across the stenotic pulmonic valve peaked at 3.9 meters per second, indicative of a maximum gradient of 60 millimeters mercury. Note also this faint signal of pulmonic regurgitation. This is the apical four-chamber view of another patient with severe pulmonary stenosis. This patient is 72 years old. We are demonstrating the apex down orientation with left atrium and left ventricle in this position, right ventricle and right atrium here. Note that the right atrium is moderately enlarged. The right ventricular cavity is mildly dilated, but importantly, note that the right ventricular wall is markedly hypertrophied. In real time, you can appreciate normal systolic function of right ventricle, normal tricuspid and mitral valves, and normal left ventricular size and function. In this patient, the 2D image of pulmonary valve was suboptimal. However, the severity of stenosis could be reliably determined by continuous wave Doppler interrogation. The maximum jet velocity was 4.7 meters per second, equating to a maximum gradient of 88 millimeters mercury. Pay attention to these presystolic signals. In patients with severe pulmonary stenosis, atrial systole results in elevation of right ventricular diastolic pressure exceeding that of pulmonary artery, resulting in forward flow in pulmonary artery during end diastole. Note also the faint signal of pulmonary regurgitation and this late peaking systolic signal indicative of associated infundibular stenosis. Please observe these features in real time now. Next, we will discuss coarctation of aorta. For 2D imaging, we utilize suprasternal notch, left supraclavicular fossa, and high left parasternal windows. Unfortunately, in most adults, the image of coarcted segment is usually suboptimal. However, in this 22-year-old patient, the coarct is fairly nicely visualized from this suprasternal notch view. Note the coarct segment is shown with a shelf-like deformity. Here is a dilated left subclavian artery. Dilated arch of the aorta is also seen. We'll see this in real time now. Note the post-stenotic dilatation of the descending thoracic aorta also. This next example illustrates the problem with 2D imaging and the value of continuous wave Doppler. We are looking at the suprasternal notch view of a 27-year-old patient. The 2D image in the region of expected coarctation is of suboptimal quality, and one cannot visualize a clear area of coarctation. Note that the subclavian artery is dilated. However, the arch of the aorta is of normal dimension. In real time, the suboptimal quality image is clearly evident. We are now performing color-guided continuous wave Doppler interrogation along this pathway. Note the typical spectral profile. The peak velocity is 3.7 meters per second, and observe that these velocities extend throughout diastole into the next systole. This is indicative of the presence of severe degree of obstruction. Observe this in real time and also listen to the characteristic audio. This case example is representative of our experience with coarctation in adults and underscores the value of continuous wave Doppler. We will now discuss cyanotic heart defects. Since it is beyond the scope of this series to present a comprehensive review of cyanotic lesions, what we wish to accomplish is to describe a systematic approach for assessment of these patients. We will then show real-time examples of a few selected conditions. For evaluation of cyanotic and complex congenital heart defects, a systematic as well as segmental approach is required. Every examination should be performed in a methodical manner with complete understanding of transducer and image orientation. We recommend that 4-chamber views should be oriented with apex down, which displays the image in a familiar anatomic format. The first step in examination is to establish the cardiac position in the chest. Scanning from the subcostal position will readily delineate the cardiac situs. The cardiac apex is usually on the left, referred to as levocardia. When it is on the right side, patient has dextrocardia. And when the apex is in the midline, it is referred to as mesocardia. It is important to remember that the image orientation of each view is the same regardless of cardiac situs. This point is schematically shown here. Study this schematic so that you can become familiar with image orientation. The next step is to establish the visceral situs. A detailed ultrasonic evaluation of the viscera and great veins is essential for complete evaluation of complex lesions. It is best to start with the views of the upper abdomen and to identify the inferior vena cava and aorta utilizing the transverse as well as the longitudinal views. Note the normal side-by-side relationship of the aorta and inferior vena cava. The inferior vena cava is on the patient's right and the aorta to the patient's left. In situs inversus, this relationship is inverted, and in some complex lesions, this relationship is altered so that aorta is in the midline and inferior vena cava is posteriorly situated. We next determine the situs of the liver and stomach. In situs solitus, liver is on the right and stomach is on the left. This relationship is inverted in situs inversus. While in situs ambiguous, the liver occupies midline position. In this example of a 22-year-old female with situs ambiguous and dextrocardia, note liver is in the midline with bilateral extensions. Aorta is also in the midline. Here is inferior vena cava, which is quite posteriorly located. Stomach can be readily identified because its contents are highly refractile due to admixture illustrated in this real-time example. Knowing the position of the stomach also helps point to the position of the spleen, which is situated posterior to the stomach and superior to the kidney. The spleen is best imaged from the flank and has a finely granular structure. Multiple spleens or absence of the spleen denotes presence of complex cardiac anomalies. Having defined the visceral situs, we now proceed with the rest of the examination following a segmental approach. Segmental approach is based upon building blocks concept and is defined as following a sequence of examinations based on anatomic connections. We start with the great veins and follow the flow of blood through the atria, into the ventricles, and into the great arteries. The challenge is to accurately identify all of these building blocks in order to arrive at an accurate anatomic diagnosis. The great veins and the venous connections are best defined utilizing the subcostal and suprasternal positions. This is the long axis view of inferior vena cava. The inferior vena cava connection to the atrium can be readily identified, and usually, but not invariably, this identifies the atrium as the right atrium. In similar manner, the pulmonary venous connection to the atrium usually will identify it as the left atrium. Look for the entrance of hepatic veins. Normally, these enter the inferior vena cava near the atriocaval junction. Occasionally, hepatic veins will connect directly to the atrium. Here are the hepatic veins, and note they connect directly to this atrium. Utilizing the suprasternal and supraclavicular positions, we can define the position of the superior vena cava and also can determine if left superior vena cava is present. This is the right supraclavicular view of superior vena cava. Here is right pulmonary artery. In real time, you can note the position and the normal flow pattern in this superior vena cava. The morphology of the atrioventricular valves, the type of atrioventricular connection, and the morphology of the ventricles can be readily assessed by observing the internal cardiac crux. Internal cardiac crux is an important anatomic landmark. It is formed by the junction of atrioventricular valves with the atrial and ventricular septa. Note that the septal leaflet of the tricuspid valve inserts lower than the anterior leaflet of the mitral valve. This simple observation allows us to confidently diagnose this valve to be morphologically tricuspid. In this anatomic specimen, note again this constant anatomic relationship at the crux of the heart. Here is the lower insertion of the septal leaflet of tricuspid valve. This is morphologic tricuspid valve. This, therefore, is morphologic mitral valve. Since the valves always accompany their respective ventricles, it also therefore identifies this ventricle as the morphologic left ventricle and this ventricle as the morphologic right ventricle. The atrioventricular connection is either concordant or discordant. The term concordance designates that a morphologic right atrium connects to morphologic right ventricle across a morphologic tricuspid valve. Atrioventricular discordance is present when a morphologic right atrium connects via a morphologic mitral valve to a morphologic left ventricle. This patient had corrected transposition. Note that the left atrioventricular valve inserts lower than this right atrioventricular valve. Hence, this is morphologic mitral valve and this is morphologic tricuspid valve. Therefore, this ventricular chamber is morphologic right ventricle and this chamber is morphologic left ventricle. Note that this patient has atrioventricular discordance. Study these anatomic specimens in detail and familiarize yourself with the normal and abnormal anatomic relationships at the crux of the heart. Let us now observe normal crux anatomy in real time. This is the four-chamber view with mitral valve in this position and lower insertion of the septal tricuspid leaflet here, morphologic right ventricle and morphologic left ventricle. This is the 2D echo of a patient with corrected transposition who has atrioventricular discordance. For orientation, this is right atrium, left atrium, and here's the plane of the atrial septum. This is the right atrioventricular valve. Note that the left atrioventricular valve is inserted lower than the right AV valve. Therefore, this is morphologic tricuspid valve and this ventricular chamber is morphologic right ventricle. This is then mitral valve with morphologic left ventricle here. Watch this in real time now. Continuing the segmental analysis approach, we next determine the ventriculo-arterial connection. This is done by combining long axis and short axis views at the base of the heart. The term concordant connection implies that pulmonary artery exits from morphologic right ventricle and aorta from morphologic left ventricle. Discordant ventriculo-arterial connection is present when aorta exits from right ventricle and pulmonary artery from left ventricle. This specimen illustrates the anatomic features of complete transposition of great arteries. Note the discordant ventriculo-arterial connection. Aorta exits from right ventricle and pulmonary artery exits from left ventricle. By 2D echo, pulmonary artery is recognized by its posterior direction and bifurcation into right and left branches, while aorta is recognized by its anterosuperior course and by origins from it of brachiocephalic and coronary arteries. This 2D echo still frame nicely shows the features of transposition of great arteries as were seen on the anatomic specimen. Having discussed the segmental approach, we will now demonstrate 2D features of these select cyanotic lesions. The anatomic features of tetralogy of Fallot can be clearly seen on this anatomic specimen. Note right ventricular hypertrophy, large subaortic ventricular septal defect with overriding aorta, and infundibular pulmonary stenosis. This specimen has been sectioned to simulate parasternal long axis view. Note here right ventricular hypertrophy, large subarterial ventricular septal defect with a dilated overriding aorta. The left ventricular size appears normal. This is the parasternal long axis view of a patient with tetralogy of Fallot. Features to note include marked right ventricular free wall hypertrophy, normal right ventricular cavity size, large ventricular septal defect, dilated ascending aorta, overriding the plane of the ventricular septum. Note normal mitral to aortic continuity. Observe these features in real time now. For delineation of site and severity of the associated right ventricular outflow tract obstruction, we utilize short axis views and continuous wave Doppler interrogation as has been illustrated under the discussion of pulmonary stenosis. Several adult patients with tetralogy of Fallot present with probable acquired pulmonary atresia. This is the long axis view of a patient with pulmonary atresia and large ventricular septal defect. The features are again similar to patients with tetralogy of Fallot, a dilated aorta overriding the plane of ventricular septum and normal mitral to aortic continuity. In real time, note that this patient has abnormal aortic valve with systolic doming. This is the short axis view of the same patient. Note right ventricular hypertrophy, dilated right ventricular cavity, and normal left ventricular size. Now we will demonstrate the short axis scan in real time. Note normal left ventricular systolic function, large ventricular septal defect, and dilated overriding aorta. Here is the atretic right ventricular outflow tract and pulmonic valve. In these patients, it is crucial to identify and size the pulmonary arteries. This is the suprasternal notch view demonstrating a dilated transverse arch, and here is a small right pulmonary artery. Observe this in real time now. Having identified the pulmonary artery, it is important to size this dimension. In this patient, it measured 1.1 centimeter. This is the frontal view from the suprasternal notch position. Here is the superior vena cava, transverse aortic arch in short axis, and now we see the right pulmonary artery in long axis. The diameter of this vessel can also be clearly visualized in this view. This specimen has been sectioned along the short axis plane. The features of complete atrioventricular canal are clearly evident. Note here is a large ventricular septal defect in the inflow position. We have here a common anterior leaflet which is attached at the crest of the ventricular septum. Common posterior leaflet can be seen in this position. The cleft anterior leaflet with the lateral half is here, with medial half in this position. Note marked right ventricular hypertrophy present in this patient. This is the parasternal short axis view of a 22-year-old patient with complete atrioventricular canal defect. This is right ventricle, large inflow ventricular septal defect, and the mitral leaflets are seen here. Observe these characteristic features in real time. Attachment of these leaflets to the crest of the ventricular septum is also clearly seen. This is the four-chamber view of the same patient. In this patient, the apex is oriented on the top, right ventricle is here, left ventricle in this position. Note large inflow ventricular septal defect and large ostium primum atrial septal defect. The anterior common leaflet is attached to the crest of the ventricular septum. These features can be vividly visualized in real time. We're looking at the characteristic features of complete atrioventricular canal defect with large ostium primum and large ventricular septal defect components evident. Epstein's anomaly is characterized by downward displacement of the septal and posterior leaflets, elongated sail-like anterior leaflet, which originates normally at the annulus, and formation of atrialized portion of right ventricle. The right ventricular and right atrial cavities are dilated. Frequently also present is patent foramen ovale with right to left shunt resulting in cyanosis. It should be kept in mind that a wide variety of morphologic abnormalities can exist. Let us now observe these abnormalities in real time. This is the parasternal long axis view of a 34-year-old patient with severe form of Epstein's anomaly. Note markedly dilated right ventricular cavity, small left ventricular cavity, mitral and aortic valves are in this position. Here is the elongated anterior leaflet of tricuspid valve and inferiorly displaced septal tricuspid leaflet in this position. Observe these abnormalities in real time now. You can also appreciate abnormal septal motion and wide excursion of the elongated anterior tricuspid leaflet. This is the right ventricular inflow view. Note elongated anterior tricuspid leaflet, which originates normally at the tricuspid annulus in this position. Here is the markedly displaced septal leaflet. This is a large atrialized portion of right ventricle. Observe these in real time now. Also pay attention to the motion of the anterior tricuspid leaflet, which appears more tethered in this particular view. This is the four-chamber view of a 31-year-old patient with mild form of Epstein's anomaly. It's left atrium and left ventricle here. This is the plane of the mitral leaflet here, while the inferiorly displaced septal tricuspid leaflet is in this position. The displacement in this patient measured 2 centimeters. Here is the small atrialized right ventricle, and note the right atrium is only mildly enlarged in this patient. In real time, observe the characteristic features. This patient had only mild degree of tricuspid regurgitation. In contrast, this patient has severe form of Epstein's anomaly. Note that the right atrium is markedly dilated. Here is the origin of the elongated anterior tricuspid leaflet. The septal leaflet is markedly displaced to this position, forming a large atrialized right ventricle. The mitral leaflet is in this position, and left-sided chambers can be seen here. The wide excursion of the anterior leaflet is evident, and in color flow mode, the severe degree of tricuspid regurgitation can also be vividly visualized. Here is the apical four-chamber view of a 34-year-old patient with corrected transposition of great arteries. In this patient, Epstein's malformation of the left-sided tricuspid valve is present. Note displacement of the septal leaflet below the level of the anterior leaflet of mitral valve in this position. Also pay attention to this hugely dilated left atrium. Here is morphologic right ventricle, morphologic left ventricle in this position, and morphologic right atrium here. This is the expanded view of the same patient. Abnormal tricuspid valve is seen here, while the anterior leaflet of mitral valve in this position. Observe the abnormal motion of these leaflets in real time now. Color flow examination demonstrated severe degree of tricuspid regurgitation, and this can be seen clearly in real time now. Single ventricle or double inlet left ventricle is a rare form of cyanotic congenital heart defect. In this condition, both atrioventricular valves are committed to a single ventricular chamber. In this anatomic specimen, here is the plane of the atrial septum. This is right atrium, and this is left atrium. Note that right atrioventricular valve and left AV valve are both connected to this single main ventricular chamber. The morphology of this chamber resembles that of a left ventricle. The diagnosis of this complex anomaly can be readily established by 2D echo utilizing the apical views. In this still frame, this is right atrium, right AV valve, atrial septum, left atrium, and left AV valve here. Note dilated single ventricular chamber and absence of ventricular septum. Observe these features in real time. Note normal motion of both AV valves with no evidence of prolapse, dilated main chamber with normal systolic function. This is the apical view of a 25-year-old patient with double inlet left ventricle. This patient has markedly abnormal right atrioventricular valve. Note that these leaflets are thickened, the ends are bulbous, and there was incomplete coaptation, resulting in severe right AV valve regurgitation. Also note marked enlargement of right atrium. The atrial septum was intact, left AV valve was normal. The main ventricular chamber was dilated as well. Watch these findings in real time now. The very abnormal right AV valve can be clearly seen. Color flow examination confirmed the presence of severe regurgitation of right AV valve. We will now turn our attention to the post-operative congenital cardiac patient. These patients represent a great challenge to the echocardiographers. The examiner must be thoroughly familiar with the type and nature of the operative procedure and with the expected appearance as well as the long-term complications. A systematic approach must be followed as has been emphasized in the previous discussion. A general approach to the post-operative congenital cardiac is shown here. The integrity of prosthesis must be established. Prosthesis may be in the form of intracardiac patches, valves, or conduits. Many congenital cardiac anomalies leave behind valvular residua and have sequelae. These must be systematically evaluated. Right ventricular systolic performance, including determination of right ventricular pressure, is paramount in the post-op evaluation. And many cyanotic conditions produced left and right ventricular dysfunction. So in the systematic post-operative evaluation approach, we must evaluate the left as well as right ventricular systolic as well as diastolic function. Now we will demonstrate examples of select post-op lesions illustrating residua or sequelae of the operation. This 34-year-old patient had a secundum atrial septal defect repaired 5 years prior to this evaluation. Persistent murmur and cardiomegaly prompted this evaluation. In this apical four-chamber view, note that the right atrium is markedly dilated and both the tricuspid leaflets are dysplastic, shortened, and tethered to the underlying myocardium. Here is a very wide regurgitant orifice present. Left-sided chambers were of normal dimension. In real time, observe the characteristic abnormality of a dysplastic tricuspid valve resulting in severe tricuspid regurgitation. Color flow examination confirmed the presence of severe tricuspid regurgitation and the atrial septal patch was intact. You can see this vividly in real time now. This 17-year-old patient had ventricular septal defect repaired at age 5. He now presented with symptoms and signs of pulmonary hypertension. This is the parasternal long axis view. The right ventricular cavity is enlarged. Here is the hypertrophied trabeculum in right ventricle. The ventricular septal patch appeared intact. Observe these in real time and note that the left ventricular cavity size is normal, but systolic function is also reduced in this patient. In this apical four-chamber view, right atrium is dilated, atrial septum bulges towards left atrium, mitral and tricuspid valves coapt normally, and right ventricle is enlarged. In real time, note that the right ventricular systolic function is also depressed, along with left ventricular systolic function. Color flow examination revealed severe tricuspid regurgitation. On continuous wave Doppler interrogation, the peak velocity of the tricuspid regurgitant jet was 3.8 meters per second. Utilizing the Bernoulli equation, this calculates to a 58 millimeter mercury pressure drop from right ventricle to right atrium. In this patient, right atrial pressure was estimated to be 20 millimeters mercury. Hence, the right ventricular and pulmonary artery systolic pressure was 78 millimeters mercury. The blood pressure of this patient was 102 over 72 millimeters mercury. This is the parasternal long axis view of an 18-year-old patient who had undergone complete repair of pulmonary atresia with ventricular septal defect. Here is the ventricular septal patch, and note that in the mid portion of this patch there is an echo dropout indicative of a hole in the patch. Note the other findings. The right ventricle is markedly dilated and the left ventricular size is normal. Mitral and aortic valves are in this position. Observe these features in real time and you'll note that the septal patch is intact except for the dropout in the mid portion. Color flow examination confirmed the presence of a bidirectional flow across this defect. In this systolic frame, note the mosaic color jet which is entering into right ventricular outflow tract across this area of the hole in the patch. In this late systolic frame, we can see the flow in the opposite direction across this defect in the septal patch. Note now the flow is in the left ventricular outflow tract directed away from the transducer and is represented in the shades of blue. Now we will demonstrate this finding in real time. Bidirectional shunting can be very vividly appreciated. For precise timing of these dynamic events, we will frequently utilize color M mode examination. Here you can see during early systole, mosaic color jet is directed across the defect into right ventricular outflow tract and can be seen here. Now, during late systole, the flow is reversed in the opposite direction shown here in the shades of blue. Note further that during the diastolic phase of cardiac cycle, there is continued right to left shunt across this defect into the left ventricle. Now observe this in real time. This recording was made at 100 millimeters per second speed for better delineation of this timing sequence. In early systole, since left ventricular pressure rises faster than right ventricular pressure, hence a small gradient from left ventricle to right ventricle is present, resulting in this forward flow across the defect. In mid-systole, the pressures in both ventricles equalize, and right ventricular pressure even rises slightly above left ventricular pressure. This results in a right to left shunt during mid to late systole across the defect. During diastole, the left ventricular pressure decline is faster than of right ventricle. Hence, right to left shunt continues during most of diastole. Therefore, this postoperative patient has systemic pressure in right ventricle with bidirectional shunt through the septal patch. This is parasternal short axis view of a 62-year-old patient who has had complete repair of tetralogy of Fallot. This patient presented now in congestive heart failure. In this view, you can clearly see this bright echo from the septal patch. It appeared intact except in its lowermost portion here where dropout is visualized. Note also that the right atrium in this patient is quite markedly dilated. Color flow examination clearly showed the presence of left to right shunt across this lower portion of the septal patch into the right ventricle. Note also a significant size jet of tricuspid regurgitation into the right atrium. Observe these in real time. You can clearly see the left to right shunt as well as tricuspid regurgitation. This is the subcostal four-chamber view. Left atrium, left ventricle here, no dilated right atrium, and right ventricular cavity is enlarged as well as the wall is hypertrophied. Observe these in real time. Now we'll demonstrate the anteriorly directed scan. Here is the ventricular septal patch, aortic valve, and in color flow mode, you will clearly visualize the shunt coming across the patch into right ventricle. Here is the mosaic color jet of left to right shunt, and as we now pay attention to the tricuspid valve, you'll also note quite significant degree of tricuspid regurgitation into this dilated right atrium. This is continuous wave Doppler examination. We are scanning from the VSD jet to tricuspid regurgitant jet. The tricuspid jet measured 4.8 meters per second. Using the simplified Bernoulli equation, this equates to a 92 millimeter pressure difference from right ventricle to right atrium. In this patient, right atrial pressure was estimated to be 14 millimeters mercury, giving us right ventricular systolic pressure of 106 millimeters mercury. In this patient, the ventricular septal jet also helps us to determine right ventricular systolic pressure. This jet measured 3.6 meters per second, which equates to a pressure drop of 52 millimeters mercury from left ventricle to right ventricle. This patient's blood pressure was 150 over 85 millimeters mercury, which would also equate the right ventricular pressure as approximately 100 millimeters mercury. This patient, therefore, has residual ventricular septal defect and associated severe pulmonary hypertension. Now we will discuss evaluation of valvular conduits. Extracardiac valve conduits from right ventricle to pulmonary artery are frequently utilized for correction of various forms of cyanotic lesions with complex right ventricular outflow tract obstruction. Retrosternal position and highly refractile nature of the prosthetic material make the 2D echo examination extremely challenging. Hence, not infrequently, conduit visualization may be suboptimal. We will now illustrate two examples of conduit stenosis which emphasize the role of continuous wave Doppler in determination of the severity of conduit obstruction. This is parasternal short axis view of a 16-year-old patient who underwent complete repair of pulmonary atresia with ventricular septal defect at 11 years of age. This is left ventricle, right ventricular outflow tract, and here is the intact septal patch. The origin of the conduit can be visualized in this position. This is the conduit valve, which is thickened, calcified, and immobile. The distal conduit is poorly seen in this area. In this patient, even though 2D echo allowed fairly good visualization of the conduit valve stenosis, color flow imaging enhanced the visualization and appreciation of the stenosis further. Note here is the level of valve obstruction, and we see a very nice mosaic color jet entering into the distal portion of the conduit in this area. We'll visualize this in real time now. Continuous wave Doppler examination revealed that the peak velocity across the conduit valve was 4.7 meters per second, which calculates to a maximum gradient of 88 millimeters mercury. In real time, you can also see presence of conduit regurgitation. This is apical four-chamber view of a 27-year-old patient who had complete repair of double outlet right ventricle with insertion of a valved conduit from right ventricle to pulmonary artery. The parasternal images were suboptimal and conduit could not be visualized. This is dilated right atrium and dilated and hypertrophied right ventricle here. This muscular ventricular septal defect could be clearly visualized on color flow examination with predominant right to left shunt. In real time, you'll see this very clearly and also note presence of tricuspid regurgitation. Continuous wave Doppler examination revealed a peak velocity of 5 meters per second across the conduit, indicating maximum gradient of 100 millimeters mercury. Can you recognize this signal? In this patient, the tricuspid regurgitant jet velocity measured 5.2 meters per second. Using the simplified Bernoulli equation, this calculates to a 108 millimeters mercury pressure drop from right ventricle to right atrium. The right atrial pressure was estimated as 20 millimeters mercury. Therefore, the calculated right ventricular systolic pressure in this patient was 128 millimeters mercury. The blood pressure at the time of this examination was 110 over 80 millimeters mercury. Hence, this patient has severe conduit obstruction with suprasystemic pressure in right ventricle and associated small muscular ventricular septal defect. In mustard operation, atrial switch is performed for repair of complete transposition of great arteries. A baffle is designed in such a way to direct pulmonary venous flow through the tricuspid valve into morphologic right ventricle and systemic venous flow through the mitral valve into left ventricle. The aorta exits from right ventricle and pulmonary artery from left ventricle. The 2D echocardiographic features of mustard operation are illustrated here. In this four-chamber view, here is a portion of the atrial baffle which separates the pulmonary venous atrium from the systemic venous atrium. Note that the pulmonary venous flow is directed across the tricuspid valve into this dilated right ventricle, and the systemic venous flow is across this mitral valve into small left ventricle. Observe these in real time. Left ventricular systolic function is normal, while the right ventricle is dilated with reduced systolic function. Now we are scanning anteriorly in order to visualize the systemic venous connection more thoroughly. Here we can see the systemic venous atrium connected into the left ventricle through mitral valve. Always we pay attention to the width of the conduit to exclude any areas of stenosis. The baffle in this patient is widely patent both on the systemic as well as permevenous ends. This is the parasternal short axis view demonstrating that the right ventricular cavity is markedly enlarged, and in real time observe that the systolic function is severely reduced. This is a frequent observation in patients after mustard repair. Left ventricular size and function appears normal. Fontaine operation is designed to divert systemic venous return from right atrium to pulmonary artery. A patch is utilized to exclude the right atrioventricular valve. ASD is closed and right atrial to pulmonary artery communication is created. This is the apical examination of an 18-year-old patient with double inlet left ventricle who underwent Fontaine repair. This is right atrium. Note here the distinctive appearance of the patch in low right atrium excluding the right atrioventricular valve from the systemic venous return. Atrial septum was intact and the right and left AV valves can be seen here. Main ventricular chamber is dilated with normal systolic function. Observe these characteristic features in real time. Note the patch in the atrium is intact and no evidence of dehiscence is present. The right atrial to pulmonary artery anastomosis is best delineated in the basal short axis scans. Here in this patient, the aorta is anteriorly located to the pulmonary artery. Here is the plane of the atrial septum, left atrium and right atrium in this position. In real time, note the normal motion of the aortic valve, pulmonary artery scan basally, and we now note the widely patent communication between the right atrium and the main pulmonary artery here. This is the magnified view of the same scan. Here's the right atrium. You can clearly see the communication between the right atrium and the pulmonary artery, which is widely patent here. This is proximal right pulmonary artery and left pulmonary artery in this position. Observe this in real time again. Color flow examination confirms the unobstructed flow into the pulmonary arteries. This 27-year-old patient underwent Fontaine operation 5 years ago for double inlet left ventricle with right atrioventricular valve atresia. In this long axis view, note that the aorta is anterior to the pulmonary artery. Here is the aortic valve and stenotic pulmonary valve in this position. Main pulmonary artery was ligated at this point here. Dilated left atrium is evident along with prolapse of left atrioventricular valve. Here is the outlet foramen, which is widely patent without any evidence of subaortic obstruction. Observe these features in real time and note marked degree of prolapse of the left atrioventricular valve. Color flow examination revealed aliasing with color reversal of flow across the outlet foramen. Here is the severe degree of left atrioventricular valve regurgitation into this dilated left atrium. Observe this in real time. Note the mosaic color jet in left atrium. Apical examination revealed mildly dilated right atrium, atretic right atrioventricular valve here, dilated annulus of the left valve with prolapse of left atrioventricular valve, and markedly dilated left atrium. Note also here is the dilated pulmonary vein entrance into the left atrium. In real time, these features can be clearly appreciated, and also note that the main ventricular chamber is dilated with normal systolic function. Color flow examination revealed a broad mosaic color jet of severe left atrioventricular valve regurgitation. This patient with Fontaine repair is now symptomatic with severe left AV valve regurgitation. In the preceding section, we have tried to emphasize the fact that postoperative congenital cardiac patients have many residua and sequelae of their operations. Hence, these patients require long-term follow-up care by a team of experts. In this tape, we have presented a systematic approach utilizing 2D Doppler and color flow imaging for the assessment of acyanotic, cyanotic, and postoperative congenital cardiac patients. Echo Doppler evaluation has had a major impact on the care of patients with congenital heart disease.